Hi everyone, welcome to Sabah ICU Congress. My name is Dr. Abdul Jabbar. I'm an anesthesiologist with a special interest in intensive care. I'm a senior lecturer in University Malaysia Sabah. The topic that I have been given today for me is the role of proportional access ventilation, PAV plus in the ICU. Before I begin, I would like to give some disclaimer. This congress and this ventilation symposium is being sponsored by Medtronic, and as part of the sponsorship agreement is to deliver this topic. Other than that, I don't have any other disclaimer. Okay, so let's move on. So what is PAV plus, proportional assist ventilation? So the very definition of PAV plus is it is a type of ventilator mode, is a ventilator mode, okay, which proportionally assisting patient in alveolar ventilation according to patient's effort. So the more patients demand or the more patient effort, the more the ventilator will give the assistance to the patient. Okay. So how do we describe ventilator mode in this current day and age? All right. So when we want to describe ventilator mode, now nowadays we will describe it according to the ventilator taxonomy, which has been developed by the Cleveland Clinic, part of the Dr. Matt Shuba, the previous speaker groups. All right. So the step one we want to see is what is the control variable. For PAV plus, it is pressure control mode. Pressure control means the machine control the breath by using pressure rather than volume, rather than setting volume. And it is actually, how is the breath sequence delivered? It's actually a continuous spontaneous ventilation, and each breath is triggered by the patient. So it is continuous spontaneous ventilation. And the third one is how about the targeting scheme? So targeting scheme is called servo. Servo means it's serving the patient, not the servo ventilator. Is meant that there's the inspiratory pressure that is given by the machine is proportional to the patient's inspiratory effort. So the ventilator taxonomy attributable group is PC CSV with a small r. Okay, so if you would like to know more about to classify the ventilator modes and to standardize the ventilator mode classification, you can scan the QR code here, and then you can read more about it. So how does the PAV plus work? So before we go into how does PAV plus work, we need to know some mechanics of mechanical ventilation. So the most important equation when you want to understand the mechanical ventilation is the equation of motion. So I would like to go through a little bit more detail here. And when we are talking about the ventilator, it's all about the motion to ventilate the lungs. Okay, so on one side we have the pressure that is pushing into the lung, and another side is the loads that will need to be overcome to distend the lung. So to expand or ventilate the lung, you have two types of loads that you need to overcome. Two types of load need to be overcome to expand the lung. Number one is the resistive load, when the air is going from the ventilator into the ETT and into the patient's airway. Then you have to encounter the resistance provided by the airways. So the resistive load consists of the airway resistance itself, and also the flow of air going through the airways. And then number two, we need to overcome the elastic load, which is given by the formula of elastance, and elastance of the lungs and the respiratory unit, lungs and the chest wall, and the volume that is being expanded inside the lung. So it is elastic load. So there's two loads that need to be overcome in order to expand or ventilate the lung. So this elastic load plus the resistive load will need to be overcome by a total pressure being generated by the ventilator and also by the patient. Mass is muscle, MUS. P mass is a pressure from the patient. Okay, so patient and the ventilator will work together to exert pressure, positive pressure, to exert pressure to overcome these two loads in order to expand or ventilate the lung. Okay, so this is total pressure done by patient and ventilator to overcome both elastic and resistive load. PMAS is the patient, PVEN is the ventilator. And when patient is just intubated, they will have fully mandatory breathing, which the 100% of the vent pressure will come from the PVEN. While when the patient is awakened and we lighten the sedation and patient starting to breathe more, some of the work will be transferred. Some of the work will be transferred to the patient, and patient will exert some PMAS. And during the course of ventilation, until the patient extubation will be extubated, there will be a shifting of work of pressure exerted between patient and the ventilator. Okay. So what is the relationship between PVEN and PMAS with regard to mode? So as I said before, until the patient is extubated, when the patient wakes up, the force or the work between the ventilator and the patient will be shifting. Okay, sometimes more on the ventilator, sometimes more on the patient. Okay, to overcome these two, elastic and resistive load. So as you can see, this is the summary by the Cleveland Clinic group in the article published by them to explain the relationship between the PVEN and PMAS between these two with regard to the ventilator mode. As you can see here, there is 3 groups of modes. Number 1 is the type of modes that if you want to read the graph, you want to understand is that you will have to see from this part. Okay, as the patient demand can increase, either according to due to worsening loads, elastic or resistive loads, or due to extrapulmonary causes like acidosis, anxiety, and delirium. When the patient demand is increasing, the first group of the ventilator mode will reduce the pressure delivered by the ventilator. That means over time, the patient will overtake the full control of the pressure from the ventilator. The more patient demand, the more work the PMAS is exerted, the lesser the pressure will be supported or delivered to the patient. Okay, so it may not be a good idea if patient is recovering and we are not adjusting the ventilator setting, because the support will be reducing over time. Another group of ventilator modes that can be described is that as the patient demand increases, the pressure delivered will be constant, like in this pressure control or pressure support mode, PSV and PC mode. So the higher the patient demand increases, the pressure delivered will be constant. Okay. And another group of mode is the PAV and NAVA, where the targeting scheme is servo R, small r. As the patient demand increases, the ventilator will increase the pressure delivered in a proportional manner. So this is called proportional assist ventilation. So the higher the patient wants, the demand, the higher the support that the machine will give, the ventilator will give. Okay. So this actually correlates well to how the ventilator and patient synchrony between patient and also the ventilator. As you can see, when patient is breathing and the ventilator giving the breath, there is actually the need to synchronize between patient and ventilator. Okay, so when patient just intubated, there is no PMAS from the patient, muscle pressure from the patient. The airway pressure, positive airway pressure that is given by the ventilator with 100% will be given, and there is no contribution from the patient. So when the patient starts to awake and starts to breathe more, there will be an interaction between and relationship between patient and the ventilator. So in this part, there need to be a synchrony between the two brains, because this is the physician or respiratory therapist brain, and also this is the patient's brain. So there will be need to synchronize. If there is no synchronization, then there will be a lot more problem that we can see in the patient who is being ventilated with the ventilator. So in proportional modes, actually, the patient drives the ventilator. Okay, not the ventilator driving the patient. So the amount of inspired time, the amount of breath, the amount of support that patients want, the higher the patient's demand, the higher the ventilator will support it. Okay, so the patient really drives the ventilator and not the other way around. So it's sort of a advanced features that can allow it to do this. So how does the proportional assist ventilation work? So to explain about this, you need to go back to the equation of motion. And in order to proportionally support, the patient, ventilator must know the loads the patient is facing. Okay. So proportional assist pressure that will be delivered by the ventilator, PVent, will aim to unload the loads that the patient is facing in predictable fashion and proportionally to the load. So the main aim for PAV, proportional assist ventilation, is to assist the patient in unloading all the burden from the patient to the ventilator. Okay. So how do the machine measure the load? Okay. So they need to measure the load and to decide on how much support to give. Okay. So this is the equation of the P vent that will be delivered by the PAV plus mode. So the equation is percentage of support times the elastance load that the patient is having plus percentage of support times resistive load that the patient is having. So we in PAV plus we set the percentage of support that we want for the patient. Ventilator need to be able to measure both loads accurately, thus to fit into this equation. So this is the elastance load, this is the resistive load. And the percentage of support will be set by the clinician, and the ventilator will calculate these two load and will calculate the support that clinician say maybe 50% support times the elastic load, elastic and resistive load, the sum of it, and this is the pressure that will be given by the ventilator, by the PAV plus mode. So we need to set the percentage support. Okay, so ventilator will calculate both elastance and resistance load every 4 to 8 breaths and adjust the P-vent support accordingly. So how do the ventilator do this? So every 4 to 8 breaths, ventilator will do an inspiratory hold, or in other terms is occlusion, for 300 milliseconds. Okay, so around the time that the inspiratory activity declining, the machine will start the occlusion, a very, very short occlusion at the expiratory valve and expiratory hole for 300 milliseconds. Okay, so at this point of time, the pressure will equalize and will show the airway pressure, which is equals to plateau pressure. Airway pressure during an inspiratory occlusion equals to passive electric recoil pressure equals to plateau pressure, and you can measure the elastance from P plat minus PIP divided by tidal volume. 300 millisecond. Why 300 millisecond? Because the researcher have studied that 300 millisecond was chosen based on studies. The behavioral response to airway occlusion have a latency of around 300 milliseconds. So in a spontaneously awake patient, very alert patient, they feel there is an occlusion and there is a latency of response in 300 milliseconds. So it means to say that if you put a 300 millisecond hold and you do whatever measurement you want to do at this time, actually it won't affect the patient and it will affect the behavior of the patient and patient won't feel anything. Okay. How do the ventilator measure the resistive load? Just now we already saw how they measure the elastance load. Okay. So how do you measure the resistive load? When the machine occlude the 300 for 300 milliseconds to get the elastance load, to get the P plat, after that, after the 300 millisecond occlusion, the airway pressure will decay here, and then will be deducted by the expected exponential reduction of P plat. Okay, so in studies done in 71 patients, the UNES have discovered that there is a predictable fashion of the plateau pressure reduction, and at the point of the peak expiratory flow, they can calculate the pressure difference. So the pressure difference is due to resistive load, P alveolar, P plateau minus the P airway pressure declining. This is the measured airway. This is the expected pressure. And then the resistance can be derived from the change in pressure divided by the flow at that point of time. Okay, so this is a peak expiratory flow. So when they do this, they can measure the total resistance. So with one shot occlusion maneuver, the ventilator able to measure both E and R, elastance and resistive load, without triggering behavioral response. And as you can see here, this is the actual mathematical formula to measure once they occlude, and then they measure the airway pressure exponential decay, as well as the expected elastin pressure, plateau pressure decay from the mathematical formula, and then the peak expiratory flow rate, and to calculate the resistive load. So with one shot occlusion maneuver, the machine able to measure both E and R load without triggering behavioral response, just for 300 milliseconds. And the PAV plus measure flow, volume, and pressure every 5 milliseconds to adjust P vent support according to percentage support chosen. Okay, and measure E and R every 4 to 8 breaths. So they continuously remeasure and readjust according to the current condition of the compliance, resistance, as well as the amount of effort by the patient. So it follows the patient. So the more the patient wants, the more the patients get. Okay. So as you can see here, what do clinician do? Very easy. Clinician choose the appropriate percentage support and will adjust the PEEP. Okay, this is two maneuver only on top of the oxygen, FIO2. So when you talk about proportionality of support according to percentage support, okay, so based on this graph, when we set the patient at 50% support, what does it mean by 50% support? So the PMAS, let's say the PMAS is given by the patient, exerted by the patient as 1 centimeter water, and percentage support of 50% means that the total pressure will be 2 and the machine support half of it. So machine will match 1 with 1 to become 2. So when you take only the P vent, 1 divided by 2 is 50%. Okay. So when you put the percentage support of 80%, the P mass actually will be amplified by the factor of 5. Okay, the support will be a factor of 5. For example, P mass is 1 centimeter water, and the P vent will be given 4, because when they become total, 4 out of 5 is considered 80% support. Okay. So this is what they mean by 50% support, not 50% of the P mass. So this is actually the percentage support is not based on the total pressure that is exerted. Is actually based on the loads, is the elastin and the resistive load of the patient, of the current condition of the patient. So as you can see, the higher the percentage support going up, the higher the proportionality. That means the amplification factor. As you can see here, this is the amplification factor of 5 of the patient effort. And when you go almost to 100%, you will be around 20 times amplified. Okay. So setting it too high also will run into a problem, like too much support, too much volume. Okay, volume overload. So talking about the ventilator setting is actually proportional. The more you want, the more you get. Okay, so it's follow the patient. So the less the patient wants, the less the patient get. So when the patient is improving, and the condition, the lungs compliance is improving, of course the effort, the demand will become lesser. So the machine will deliver lesser amount of air to the patient. So how do I use PAV plus? As you can see here, in order for the machine to calculate the resistive load, you need to key in what type of the airway the patient is having, either endotracheal tube or tracheostomy tube, and you need to key in the tube diameter. So either 8.0, 7.5, 7.0, and then you need to ensure the safety parameters have been set properly, like total, the maximum tidal volume, peak airway pressure, and so on. Okay, and then you choose the initial percentage support. Okay, so this you can choose here, percentage support, the FiO2, and also the peak. So initial setting has been suggested to be at 70% assist. Okay, the percentage support at 70% initial setting. So when the patient is being just intubated for, let's say, pneumonia, having oxygenation issue, so at first, probably, usually most of the time, patient will become, the P vent will be 100%, there is no P mass. Fully, the breathing will be fully by the ventilator. And then once the patient gets better, after being given antibiotic, and then the oxygenation improving and the compliance improving, and it has been suggested at the level of compliance of more than 20 liter per centimeter water and good oxygenation, compliance more than 20. And you can think about to adjust the ventilator set modes to PAV plus. So when you set the initial setting at 70%, you have to see the response clinically. If the respiratory rate is less than 35 and the volume more than 5 ml per kilo, you can observe for 5 to 10 minutes. And then if there is no distress and respiratory rate, compliance and resistance same or improving, you can further reduce the assist to 10%, 10 to 20% every 2 hours if no respiratory distress and either respiratory rate, compliance or resistance similar or not improving, static or improving. And then after that, when further after the patient getting better and better, if there is no distress at percentage support of 20% and PEEP of 5 or less, we can consider extubation or spontaneous breathing trial, either using TPs or low PS as a SBT. Okay, so if the patient having distress at more than 20%, and you cut down from 70 to 60, 50, 40, 30, if patient having distress at any point of time, or the compliance is reducing or resistance is increasing, you can increase the assist back from 40 to 50 again, or 50 to 60 again, increase the previous value or increase back slowly, and you can wean further slowly for the patient. You don't need to wean very fast. Okay. And also, if there is a distress issue, you can go to this increased PEEP in steps guided by compliance. Okay. So we go back to the top. If the patient having respiratory rate of more than 35 and VT less than 5, you can increase the PEEP by 2 to 3, and then you observe again. And if there is distress, clinical distress, or RR, respiratory rate, compliance, and resistance deteriorating, you can go to the PEEP increment steps guided by the compliance. Okay, so if there is no distress, good, then you can do slower weaning because patient having distress at this step. If the distress continues, you can increase the percentage assist in steps up to 90%. If distress still continues, switch to another mode. So sometimes when you the usual clinician experience when starting to use the PAV plus is that the patient appears to be under assisted despite near maximum percentage of unloading, 70% to 80%. Means you already set percentage support of 70 to 80%, but you still note that the patient is tachypneic and the tidal volume is not achieving, and you try to increase the PEEP 2 to 3 the first step, but the response is not that good. So there is 3 possibility. Okay, so the first possibility is high ventilatory demands. That means the compliance is worsening, or there is any other problem issue with the hypoxia, very high grade fever and delirium, anxiety that can cause respiratory drive is very, very high. That means patient is not suitable for PAV plus. This is one of the type of patient is not suitable, high ventilatory demand. So you may need to think of safety to protect the lungs. Probably you need to sedate and probably need to paralyze if patient really is having high ventilatory demand, high ventilatory drive, which can cause pressure. So patient self-inflicted lung injury. Okay. So another two possibilities that the patient might be having low compliance because the patient is at the low lung volumes. As you can see here, if you are familiar with this curve, pressure volume curve, our lungs have this sinusoidal shape of compliance, in where when the lung volume is smaller, the compliance is low. When the lung volume is higher, the compliance is also low. So the best compliance will be at the middle part of the lung volumes. Okay. So the theory is that when you imagine there's a balloon, if the balloon is small, that means the tightness of the material of the rubber is actually quite strong. It's very hard to expand the balloon at this point of time. So our tidal volume when we ventilate patient will be like this. Tidal volume. Okay. So when we do this, actually it's quite hard if the balloon is small. Okay. It's also quite hard to distend, deflate and inflate continuously if the balloon is too big. So the compliance in both sides is very big. Okay. So using this concept, the patient might be having low compliance due to patient is at the lower lung volume. So how to solve this issue? We need to increase the PEEP until C compliance that is measured by PAV no longer increases. So when you increase the PEEP by 2, you need to see at the monitor the CPAF compliance increase. If there is no more increase, then you can stop the PEEP increment. So the concept is that when you increase the PEEP, the total lung volume, the current lung volume that is being ventilated at tidal volume breath is higher than it is at the steep portion of the curve. That means the balloon is at the right size, having the highest compliance. Okay, so it's easier to distend the lungs, inflate and deflate the lung when the lungs is at the optimal lung volume, at the optimum PEEP. Okay, so when we talk about assist to the patient, when the compliance is when we aim the best compliance, a better compliance will lead to better actual volume assist by the PAV plus because of the formula. So you need to increase PEEP in steps until CPAF no longer increase or the elastin PAF no longer decreases. Okay. So another one is dynamic hyperinflation. So when there is dynamic hyperinflation, the patient seems to be not supported well enough. Okay, why? So in dynamic hyperinflation, there is a failure of the respiratory system to reach passive FRC at the end of aspiration in the case of obstructive disease. Okay, so we need to increase PEEP incrementally and watch for clinical dyspnea improve. So how to explain this? Okay. So when without extrinsic PEEP, P must overcome the elastic pressure in order to trigger the ventilator. Okay, so the patient must go from here to the zero to go up to have some value for the machine to detect and to trigger the breath. Okay, so but with PEEP, extrinsic PEEP, the P must overcome the elastic pressure minus the extrinsic PEEP in order to trigger the ventilator, because it's already bring up the total pressure and it open up the airway, like a waterfall effect to be able to for the patient to trigger the ventilator easier. Okay, so if you see at these figures, when the patient have no auto PEEP, there is airway pressure 0 here, and airway pressure in the alveolar is 0, and the plateau pressure is 0. This is at the end of aspiration. And when the patient inspired, actually patient is exerted pleural pressure of -5 that will distend the alveoli, creating a negative pressure -5. And inspiration occur because there is a gradient of the pressure that will cause flow of air into the lung. So if you have auto PEEP, at the end of aspiration, the airway pressure is 0 and the alveolar pressure is 10. When the patient try to breathe in, there will be a very high effort to overcome this +10 inside the alveolar to cause to generate negative pressure inside the alveolar. Okay, so auto PEEP of 10 and the external PEEP of 10. So what happened when you apply external PEEP of 10? Okay, so you apply external PEEP of 10 here, the alveolar air trapping +10 here, the plateau pressure +3 at the end of aspiration. Patient only need to generate -3 plateau pressure to create a alveolar pressure, to drop the alveolar pressure by 7, just a little bit less than 10, less than external PEEP, for the airway, for the airflow to go through, for the gradient to be present and the airflow to come through. So this is the theory of why we need to use external PEEP in order to treat obstructive diseases like COPD patient. Apply external PEEP to counter auto PEEP or dynamic hyperinflation. So the patient will have less dyspnea the higher the external PEEP when you apply to the patient. And so you increase the PEEP incrementally and watch for clinical dyspnea improve. This is true not only for PAV+, also true for the other type of modes. Okay. So an experimental study have been done. If you put the esophageal pressure, and then you can see in the dynamic hyperinflation, patient will be very dyspneic. You see the esophageal pressure will go very high. So that means contraction of the diaphragm is very high and is very significant, is very strong. This is not good for the patient. This patient is having dyspnea. Okay. So when you put a PEEP of 10, you can see the esophageal pressure is a bit more calm, doesn't expand very strong, and there will be a decrease in esophageal pressure excursion. So it will not hurt the patient very much, and patient will be more comfortable. Okay, so this is the theory when you put a PEEP of 10 for the to treat the dynamic hyperinflation, external PEEP to treat dynamic hyperinflation. Another way to visualize this is that when you have auto PEEP, this is the analogy of waterfall. So when you put the external PEEP over here, and then they will help to open up the pathway. So and then when they increase the upstream pressure over here, so that the patient only need to use small amount of muscle effort to reduce the pressure in the alveolar for the airflow to comes in. Okay, all you need is a pressure gradient. Okay, to cause the air to go in, to go inside, for the patient to ventilate the lungs. Okay. So without proper PEEP titration, the effectiveness of PAV plus may be decreased. So when you have dynamic hyperinflation or low compliance, both can be treated by increasing PEEP in steps until CPAP no longer increase. Or in the case of dynamic hyperinflation, you can watch for the clinical dyspnea to be improved. So what is the role of PAV plus, PAV plus? My main topic for today. So when we talk about mechanical ventilation, you need to be aware of the goal of mechanical ventilation. I like this idea or this concept have been given by the Cleveland Clinic group, the Matt Schuber group, the Eduardo Morales group. So we can visualize the goal of mechanical ventilation throughout the patient's journey in the being mechanically ventilated. So of course, when the patient being after just intubated, patient will have poor oxygenation, poor compliance, and very bad lung, very whitish X-ray. So you want to think about goal of mechanical ventilation as safety. So you want to target low tidal volume, you want to target low deriving pressure, low plateau pressure, low outer PEEP, low mechanical power. And then as you can see here, as the resistive and elastic load high, usually we will use fully mandatory breaths at this point of time. So as the improvement of disease process occurs, we want to think about giving comfort for the patient, wake up the patient, reduce the sedation of the sedation. At this point of time, there will be a lot of synchrony issue, and the goal is to winning and optimal synchrony. And this current goal is not to extubate yet. This is the current goal for this phase. The next phase is comfort. The next part is the liberation. When you want to about to extubate the patient, you become much better, and the spontaneous breath has become more, and you want to optimize the synchrony, you want to do spontaneous breathing trial, and you want to aim for extubation. So this is the concept of goal of mechanical ventilation. So where do this PAV plus sits? Okay, so usually when we use mechanical ventilation, the mandatory mode, we will start by changing to PSV around this point when the patient is we already reduce the rate of the mandatory ventilation, we adjust the inspiratory time and so on. And after at one point, we want to think about changing to pressure support ventilation to wean the patient. And after that, we will do SBT by using lower PSV. Okay, so where do the PAV plus sits? So I would say PAV plus is an early weaning mode that we can apply quite early in the patient's journey, in the patient's recovery from the lungs problem. Okay, so you can start PAV plus early as an early weaning mode, which is quite safe. I will tell you in a bit. So you can still continue this by reducing the percentage support as the patient improve in their disease process. So you can start early, wean early. It's quite safe and comfortable for the patient, actually better synchrony, and you can use throughout until the patient will be extubated. Okay, might take few days, but you can go use it throughout the course of the rest of the mechanical ventilation days. So as soon as oxygenation improving and compliance improving, recommended more than 20, at this point of time, sedation will be stopped and patient started to wake up. Now the patient at the higher risk of ventilator desynchrony. This is the best time to change to PAV plus mode, which is early. We can start with 70% support and may follow clinical assessment to further reduce the percentage of support. So the main role of PAV plus is actually, for me, I can conclude is that like a smart and safe early winning mode. There is earlier, you can do earlier and safer change to spontaneous mode. Patient and ventilator interaction become more optimum. It can create, actually by research, it shows that it has a greater respiratory muscles efficiency, improve patient ventilator synchrony, neuromuscular coupling in gaseous exchange. When you have ventilator desynchrony, it will lead to poor outcome. And with PAV plus, you can provide high level of assistance or unloading the respiratory muscle early in the disease while preserving the safety because the ventilator following the PMAS level, the patient muscle effort. And another role of PAV plus that have been talked about in the scientific groups is that the PAV plus seem to have a diaphragm and respiratory muscle protection. How so? Okay, so when you, as you can see, when the patient demand increase, PAV plus support proportionally higher PVent. Of course, when the demand increase, the machine give more. So the tidal volume increases. When the lung expand, there will be hearing bureau inflation inhibition biological feedback mechanism that will send the message to the brain to downregulate the respiratory drive, and the patient neurorespiratory drive reduces. So the PAV follows to lower the support for the patient because the drive is reduces. And then diaphragm stimulated again and optimally used. So the volume renormalizes back again. So at any point of time, if the compliance reduce, extrapulmonary respiratory drive increase for any reason, the patient demand increase, the puff support will increase proportionally, giving higher pressure. And this will serve to avoid hyperinflation and preserve diaphragm function. Okay, so how about PSV? When the patient demand increase, PSV will always provide constant pressure. Tidal volume increases, okay, because the patient demand increase, but the ventilator is the same. Of course, in total, tidal volume will increase. So hearing bureau inflation inhibition biological feedback mechanism will downregulate the respiratory drive. Patient neurorespiratory drive reduces, but the PSV still provide the same pressure. Okay. And diaphragm less stimulated, less contracted, and because the assist is still the same, it will be over-assisted by the same pressure. We can cause tidal volume stacking, over-assisted pressure support. It can cause, so as the time goes on, if there is compliance reduced, extrapulmonary respiratory drive increase, when the patient demand increase, this vicious cycle can go on, can cause the risk of hyperinflation higher likely than in PSV, risk of diaphragm atrophy because of the less stimulated diaphragm when this thing occur, and can also cause cycling and failed trigger desynchrony. So another way to explain this is that PSV actually shifted up the PMAS over VT relationship. Okay, when the patient effort increases, the tidal volume and the response is also increased. Okay, so this relationship is increased, shifted up because pressure support is constant regardless of patient effort. So as the patient effort reduces due to protective reflex, even minimal patient effort will trigger a minimal tidal volume. Okay, so it will give false assurance to the clinician that patient is spontaneously breathing well, but in actual fact, patient just give a little bit of effort, and the patient already get the volume. This may lead to diaphragm disuse atrophy. As you can see here in the same article, it shows here that when this occur, over-assistant support breath even with minimal effort can be seen here. The airway pressure generated by the PVent from pressure support trigger, but actually the contraction from diaphragm is almost none. Okay, so it can lead to disuse atrophy. So actually the disuse atrophy, and it will increase the mortality rate. So the goal is that to keep diaphragm working. Okay, so which is not there if you use PAV. As you can see, if the muscle pressure increases, the tidal volume generated by the machine will be increased proportionally to the patient. So when the effort reduces, the ventilator P vent by the machine also reduces proportionally, and the tidal volume reduces. This will stimulate back the patient to breathe and to keep using and working the diaphragm. So this can prevent the disuse atrophy for the diaphragm. Okay, so another based on research, you can see we can have earlier extubation than pressure support PSV. As you can see, zero Chucky have shown the probability of remaining on spontaneous breathing is longer if you use PAV plus compared to PS, because some of the patient will be converted back to the mandatory mode. So another main role of PAV plus is to think of it as a smarter weaning mode. Because it will improve patient ventilator interaction, it provide high level of assistance or unloading of respiratory muscle earlier in the disease, safety preserve following PMAS level. It will reduce frequency of work shifting on the ventilator. Mandatory modes and PSV, as patient demand increases, assistance still the same in VC mode. However, in VC mode, pressure is delivered even reduced. Okay, so this will lead to severe desynchrony of mismatched respiratory flow demand. Okay, in comparison to PAV plus, as the patient demand increases, assistance will be increased as well. As the patient demand reduces, assistance will be reduced to protect the patient and to keep working the diaphragm. All right. However, in VC mode, as the patient demand increase, assistance will be reduced, and the pressure mode will be constant. So it will not follow the patient. There can be a mismatch of inspiratory flow demand. Because PAV plus provide proportional matching to patient inspiratory flow demand, there will be actually the theoretically less likelihood to have desynchrony in terms of matching the inspiratory flow. And when you have this, there will be less trigger and cycling desynchrony as well. PAV plus also reduces major asynchrony. In the study done by Zero Chucky, is that, as you can see here, during patient is sleeping, for the amount of asynchrony is much higher than PAV. It can be shown also in wakefulness. The amount of the major asynchrony occur around 4 times higher compared to the patient on PAV plus. Okay, so another study shown that PAV plus improves sleep in ICU. As you can see here, when patient is on PSV, they have much higher incidence frequency of asynchrony, auto-triggering, delayed cycling, and total asynchrony. Thus, compared to the patient with PAV, they have much less asynchrony, asynchrony and desynchrony. So when they have less desynchrony problem, and they will have the combined effect of fewer arousal per hour, fewer awakening, greater REM sleep, greater slowest sleep, accounted for the significant difference between the PAV. So it favors the PAV. So it's been shown here, not only it reduces the asynchrony, it also improves sleep in this group of patients that has been studied. So we can look at some case study. So this case study is 55 years old gentleman, and day 7 his oxygenation was improving, PF ratio increasing, he started to have new frequent short-lasting desaturation. Clinically, he was uncomfortable moving about, attempting to bite the ventilator. So the ventilator waveform shows like this, okay? Okay. So if you read the Cleveland Clinic group paper, you can understand and you can learn about how to read ventilator waveform like very systematic, like uric and ACG, very systematic. So step 1 is to define the tag. In this patient, patient was on SIMV-PC, and according to the ventilator tag is pressure control, intermittent mandatory ventilation, PCIMV, and we can see the load. The patient have a quite significant PMAS load, and the patient ventilator interaction is work shifting, late cycle, and early trigger. For the scope of this talk, is a bit too detailed. Okay, so step number 4, we are define goal. For this patient is actually safety, is between safety and comfort zone. Okay, so this mandatory breath machine triggered. Actually, this is early trigger, which is followed by the evidence of PMAS. Okay, what I want to show you is that in this patient, the patient is having PVMAS work shifting because as you can see, the pressure at the end of pressure, the pressure goes up, and the inspiratory flow is having this increased concavity after when the patient is breathing. So patient is currently having higher demand than usual, and most of the demand is being met by the patient alone and not by the ventilator. Ventilator didn't match the patient demand. Okay, as you can see here, as the patient severity of work shifting increases and the work burden increases, the concavity will be increased. Okay, so when there is a severe work shifting or flow starvation, the most of the work will be given by the patient. Okay, and this can cause increased work of breathing, increased dyspnea, and this is not good for the patient. Okay, over time, patient will maybe desat, will get worsen oxygenation. Okay, remedial action depends on the patient condition and current goal of mechanical ventilation. So for this patient, I will take in around safety and comfort. So if a patient is still in this, we need to prioritize safety. So in volume control, we can adjust we can sedate the patient, paralyze the patient, we can control 100% of the ventilator modes, the ventilator tools. Okay, so if the patient is we think this is going to be, the goal is going towards comfort, we can change to pressure spontaneous mode with a good amount of pressure support, or we can use PAV plus. So remedial action in this case is that I did change to PAV plus, and although the C5 is still quite low, when we change to C5, when change to PAV plus, we can see there is an immediate improvement of the synchrony, there is no asynchrony, and there is much better clinically, patient is not so much dyspneic. Okay, so you can see here, you can see there is just now how the machine measure the elastic and resistive load. Okay, so you can imagine if we change to pressure support, as the patient demand increase, the pressure will be delivered constant and will not increase. And at this point of time, in between safety and comfort, I think the PAV plus was a better choice, because as the patient demand increases, the pressure delivered assistance to the patient will be also increased. Okay. However, you should be aware that PAV plus should be carefully applied in patient with significant respiratory circuit leak, because the machine unable to calculate E and R. Also, patient with inefficient drive, either oversedated, recovering from neuromuscular paralysis, because the patient drive the ventilator. So if the driver unfit to drive, so at least not yet, we have to postpone a bit. And you have to remember, don't use this on a chronic critically ill patient or difficult to wean patient, because neuromuscular or disturbance to brain respiratory muscle pathway can lead to problem and trouble when using this mode. Okay, PAV plus requires good coordination between patient's brain, demand, and neuromuscular transmission. Ventilator assume airway pressure changes lead to instant reaction from neuromuscular pathway. So another thing is, if a very severe COPD patients or any condition with significant air trapping, you may need to be careful to apply this. So conclusion, one of the best data or evidence so far in this latest meta-analysis plus trial sequential analysis has been published in year 2020. It has been shown that PAV improved the weaning success in patients with mechanical ventilation. As you can see, the I-square heterogeneity is 0%. That means almost all studies concur and say the same thing. The weaning success is better in PAV compared to PSV. All right, so PAV is associated with higher rate of weaning success, a lower reintubation rate, and shorter mechanical ventilation duration. Okay, so to summarize, PAV plus can be thought of like a safe early weaning mode, and PAV plus actually have been proven to improve weaning success, and it is an earlier and safer change of spontaneous mode. Rather than using PSV, better use PAV plus, so you can use earlier. It has diaphragm and respiratory muscle protection, and you can think of it as a smarter weaning mode, because PAV plus reduces major asynchrony, and it also improves sleep in the ICU. And at the same time, you can have earlier extubation compared to PSV. So final word, PAV plus is a simple mode. You just need to adjust the FiO2, percentage assist, and PEEP. Respiratory system mechanic and driving pressures are semi-continuously estimated to match the patient. The more the patient wants, the more the patient get. The lesser the patient wants, the lesser the patient will receive. So it is a positive feedback mechanism and will continuously keep check of the patient and will continually taking care of the patient when you are not there at the patient. Actually, you can use PSV. If you are there and with the patient all the time, you can increase the PS up and down, continuously calculate. So PAV plus is like a PSV, smart PSV, PSVI, PSV intelligent. So the intelligent part is if you always there in front of the patient, yes, you can use PSV. You can see the patient demand increases, then you increase the PS. If you see the patient demand reducing, then you reduce the PS. Okay, but for PAV plus, they are doing this automatically, continuously when you are not there with the patient. So you can be rest assured that the patient has been taken care carefully with the PAV plus mode. Okay, so towards improving patient comfort, keeping it simple, safe, and smart. So use PAV plus. Thank you.